The next speaker is Charles James. And Mr. James has been CEO of North American Healthcare Management Services. That's a medical billing company since 1992. His family has owned several clinics in the 1970s and 80s, which became some of the first certified rural health clinics in Missouri. Those family-owned clinics were purchased by a large hospital system in 1991. Charles has worked with rural primary care providers, small rural hospitals, and community health centers across the country ever since. He has served on the boards of several rural health associations, including a term as president of a national organization during the COVID-19 epidemic. Charles provides technical expertise to rural health associations across the country as a frequent speaker. And Charles has spent many years lobbying members of the U.S. House of Representatives and the Senate on issues affecting the delivery of rural primary care. So please welcome Mr. Charles James.
Thank you very much for inviting me to be here. I appreciate the opportunity to speak with you. I'm going to be super boring relative to the testimonial we just got from these three ladies. I'm much more technical, but just to tag on to what Chastity said, I too was shocked when I looked up maternal mortality rates in the U.S. Not only are we at the bottom of industrialized nations, the last UN statistics had us between Belarus and Saudi Arabia for maternal mortality. And people are shocked when they hear that. I like to say we have the best healthcare and healthcare providers in the world. We have one of the worst systems for financing the care that we give. A lot of folks say, hey, we're a Christian country, but our healthcare system sure doesn't seem to reflect a lot of that. So thank you for all of your comments and testimonial on your experiences. It's just so scary what can happen to people when we don't have healthcare coverage. And all of us, rich, poor, white, black, brown, yellow, are just one health crisis away from bankruptcy. Medical bankruptcy is the number one driver of bankruptcy in the country. And how is that possible? So I do this a lot. I go around, give a lot of technical discussions about various micro issues related to our little niche of rural healthcare. So a little bit about me is my family, my dad's brothers were all doctors in central Missouri. And my uncle, they were a family practice guy, delivered babies, general surgeon, internal medicine. Family practice guy delivering babies delivered like 3,500 babies in a town of 2,600 people over the years. And I will tell you that how much things have changed. He delivered every single one of those babies and saw every one of those patients with two guns on him. Always had one on his belt and always had one in his boot. And you just think about that clinic operating now, and the world has changed several times since then. So I grew up with those guys, and we grew that organization into 9 locations, which at the time was very large, and 8 of those became rural health clinics, which I'm about to explain what they are. So I grew up in that. I said, I'm never going to go to work for the family. So, of course, exactly what happened is I got out of school and went directly to work for the family, and I've been doing this since 1991. So I thought in order to get our heads around what's happening in Congress with the One Big Beautiful Bill, that we really need a little bit of history about what the ACA is exactly and how it's structured, so we can talk about the potential damage that the One Big Beautiful Bill will do. Directly to Chastity's point, one thing I didn't even address in this are the maternal healthcare deserts that we're creating. What somebody like me doesn't realize is that an enormous percentage of our patients have massive transportation security problems. And getting 30 miles is a non-starter. Getting 5 or 6 miles to the doctor is a problem when you don't have a ride. And with these healthcare deserts come food deserts as well. And we just have this cascading series of problems that have large negative impacts on all of our community's healthcare. So I'm going to talk about these issues here. And I originally had this slide titled Original Sin, but I thought maybe that was too strong. So first of all, why do we have the healthcare coverage we do? Because after World War II, there was a big salary freeze, and labor shortages created an economic problem, and employers discovered we can't pay more. We have salaries frozen after World War II, so health benefits were not taxable, and we can attract workers by offering benefits through our employment. That's how this started. And then the federal government said those benefits are not going to be taxed, which is one thing Obamacare started to change. So this started way back after World War II, and then we were talking beforehand about the HMO Act of 1973, which codified not only for-profit medicine, which is what I refer to as our original sin. Profit motive in healthcare is our original sin, and what has really created a lot of negative consequences for our whole system. But it's also when HMOs and PPOs, point of service care plans, became prevalent. And then when my family were growing our organization through the 70s, we actually had one of the first HMOs that was very unsuccessful, and it drove it right into the ground because of overutilization. And again, it was a profit motive that created this problem. But that's when our PPOs, HMOs, really got off the ground. So PPOs, preferred provider network. So think, oh, I have to go to this doctor that takes my insurance or else my claim is not going to get paid. So that's where all of that started. So I like to ask people, hey, who would you say runs our healthcare system? What would your answer be? CEOs. Who's that? CEOs. Good answer. Insurance companies. That's exactly right. I expected some of us to say, oh, the federal government runs it. Oh, Medicare runs it. No. As my attorney says, the golden rule is they with the gold make the rules. And so that's exactly where we are today, is the health insurance companies are running the show. Let's face it, sorry, politicians. A lot of our politicians' funding comes from healthcare companies, health insurance companies of all kinds of stripes, and there's a lot of power. There's a lot of economic power there. Healthcare is 25% of our economy. So there's a lot of money to fund political campaigns, and that's absolutely what happens. Our niche in healthcare has been with these types of providers: rural health clinics, critical access hospitals, community health centers, and all of these types of providers get paid based on their cost. So they have a very different reimbursement structure than if you go to Memorial Hospital and see a doctor in what we call a fee-for-service environment. Fee-for-service environment, you submit a claim for $200. Your insurance company is going to pay some strange allowable amount of that, which may be $83.37, and the insurance company writes off the difference. Who suffers in that scenario? Self-pay patients suffer because they pay the full amount of that healthcare claim. So our rural health clinics, our critical access hospitals, our community health centers are paid based on what it costs them to see a patient, plus a lot of variables. But most of our healthcare providers in rural areas are one of these three types of entities. And to show you how pervasive they've come, here are all the rural health clinics in the country. Now look at Illinois, and it's covered up, isn't it? It's covered up. So, of course, these rural health clinics correspond to population centers, so we have fewer of them out in the Desert West. And we're really focused here in the Midwest and the SEC territories, et cetera, and down into Texas. And actually, for a while, Missouri had the most rural health clinics in the country. And this is who we have served at our company primarily. Heavy Medicare, Medicaid populations. We rely on Medicare and Medicaid in our rural health clinics. That's who we're seeing. We typically have about 50% of our patients are Medicare, Medicaid. Another 35, 40% are commercial insurance, and another 10% are self-pay. And the reason we have such a low self-pay percentage is because of the Affordable Care Act. And we're going to talk about that momentarily. Here are critical access hospitals. I can't see the map very well. Where's Illinois? But you see in southern Illinois, and especially when you focus in on Illinois Congressional District 12, which we are, it's a huge district. We cross the entire state, and most of the hospitals that we think of in our district, Redbud, Pinckneyville, Nashville, Crawford Memorial in Robinson, Lawrenceville, wherever you can think of, except Belleville, are critical access hospitals. And they get paid basically 101% of their cost. Now, these critical access hospitals and rural health clinics have been suffering from what we call sequestration, which actually came about in the Obama years, which is a 2% haircut on every Medicare dollar they earn. So for every Medicare dollar they earn, they get paid 98 cents. You would think that is not much, but it actually has had an enormously negative impact. These critical access hospitals may run on a 1% or 2% of a profit margin. So if you take 2% away, you're taking away any money they make that then goes directly and takes away from ancillaries and other services. And what's the first thing to go? OB care. So we've had an enormous wipeout of OB care in these critical access hospitals because they just can't afford to staff and keep an OB unit. So already, this has already happened. We've had an enormous number of OB units across the state close, and this has been something we're battling. And then we hit this OBBB problem. So more about that in a second. Then our community health centers is a federally qualified health center. They get a couple different kinds of federal advantages. And when you hear community health centers discussed, they're typically some kind of FQHC. And you can see down in southern Illinois, we actually have one big giant community health center that serves a lot of southern Illinois, which is, you may know of Southern Illinois Healthcare. They're a big, well-established, well-entrenched community health center in southern Illinois. And so these three types of entities, once you get out of any kind of urban, suburban area, are probably where you're being seen. Everybody in our industry is terribly fearful as soon as this one big beautiful bill hit. It's been we're all fearful of impending catastrophe. Everybody's fearful of the uncertainty. One thing that happened to community health centers when the new administration took over is all of our grant funding got frozen. It was like a missile strike from our own capital. Because what happened is our community health centers, is like if you go to your bank and they say, sorry, you can't get to your money right now. So they draw down on grants and they could not access their grant money. And then we thought, oh, wow, okay, we're in a new environment here. This is something different and not good. And then we get the One Big Beautiful Bill Act, and now, you know, the healthcare Armageddon that I've been fearing is a distinct possibility. Let's look at some Medicaid facts. Let's look at some facts, not political propaganda designed to degrade certain populations in our country. 19% is Medicaid funding. 25% of our, this is our healthcare spend, sorry. Hospital healthcare spend in 2023. The statistics run a couple years old. For any of your research, I highly recommend Kaiser Family Foundation. They are a singular, preeminent source of nonpartisan, in-depth information. So when you hear Kaiser Family Foundation reporters on NPR, for example, you can put it in the bank what they're saying. They're nonpartisan, extremely well-developed organization, and they have great website resources. And almost everything I'm presenting to you today comes from Kaiser Family Foundation, including this map. So here's our spend, 25 and 19%. Boy, that's sure getting about 50% of our spend, isn't it, in healthcare? Yet we still have outcomes like Belarus and Saudi Arabia. How is that possible? How is that possible? Let's look here. Medicaid in Illinois. Medicaid adults. Remember from a previous administration when we had this term that, oh, they're a bunch of takers? Remember that? No, they're not. We're working. We're working. 70% of our Medicaid recipients are working, and the rest of them are not working, probably because of some kind of disability, or maybe they're in a nursing home. 69% of our nursing home residents are on Medicaid. How many of you have had family members that had to get rid of everything they have so they can afford to go into a nursing home? That's how. So when we're talking about Medicaid recipients, we're talking about people who are already working. We're talking about people on disability. We're talking about children. And we're talking about nursing home residents. And yes, expectant mothers get Medicaid benefits. So that's who we're dealing with. 13%, look at our district here. Medicaid covers from 13. I don't have an exact number for District 12, but we'll get there. Here's some what I thought were interesting demographics specific to our district. 26% of our residents, over a quarter, are on Medicaid for the reasons we just looked at. 7.2% are uninsured. You know why only 7.2% are uninsured? Because the ACA worked. That's what the ACA was supposed to do. It got people insurance. And you know how frightening the prospect of not having insurance is with a catastrophic diagnosis. 20% live in a designated primary care shortage. It's actually a very specific status for our counties. All of those counties that you see that had critical access hospitals, rural health clinics, or community health centers are all primary care shortage areas. You have to be in one to get one of those status. Now here, I want to ask a question before I show this next slide. What do you think the percentage of people are that have fast, high-speed internet and a computer to operate it at home in Illinois? Guess what percentage would you think? 50. That's a really good guess. It's exactly right. 58%. Now, this is actually a little higher than a lot of places. 58%. So I want you to think about something. How do you go apply for something, a job, or anything else if you go home and you don't have the internet? Are there paper applications anymore? How about if you're having to go prove that you're working to get Medicaid? Where do you think that application is? Online. So only 58%. Now, do you think it's the Medicaid households maybe that have? No, of course, they're the ones that don't have largely internet at home. So that's an enormously important statistic. And during the previous administration, there was a big effort to fund fiber optic expansion, internet expansion. It's a utility now. And that is no longer a priority. 16% of children are in poverty in our county. We have a very wealthy county. In our district, I should say. Monroe County, we're lucky because we're a pretty wealthy county, but those around us are not so. And then 18.3 teen births per 1,000 females, average of, what's our average? I think that's 18.3%, excuse me. So I'm screwing that up. But compared to the national average, it's 13.5. I think that stat's a little messed up. And I got all these stats off this congressional dashboard. Okay. If you go to certain politicians' offices, and I won't name any names or use any partisan labels, but an enormous part of the response I get is, hey, if you just kick, and I will not use the term I will use is undocumented immigrants. If you just kick all the undocumented people off, insert different language, all these cuts will pay for themselves. Well, no, it's not true. Undocumented people do not have access, as Chastity was talking about. They have emergency access. So all of the conversation about, hey, well, just go to the emergency room if you're sick is just wrong-headed at best. So undocumented immigrants do not have access to federally funded benefits of any kind. That is a fallacy and is an argument made to justify a position which is baseless. They may qualify if we have certain types of protected status, lawfully present immigrants or qualified immigration status. And of course, what are we trying to do? Go after all the people that have qualified status here. These are the folks that can get federal benefits. If an undocumented person shows up to a community health center, the community health center is obligated to see that patient regardless of their ability to pay. Just like an acronym EMTALA, which is emergency medical, whatever TALA is, that requires people, the hospital, to see a patient in an emergency situation. Now, our critical access hospitals are required. They have 72 hours to keep a patient. You keep the patient for 72 hours, you get them stable, you ship them out. That is a requirement of the program of critical access hospitals. So there's some emergency care that's available, but folks that are not here on a qualified status cannot get Medicaid. So that argument, do not accept that argument from people. It's untrue. I have to sit on my mouth, sit on my hands. I have to put my fist in my mouth when I'm in a politician's office and they start saying this to me. Now, you can tell I'm probably not the most conservative guy in the world. But I work in an extremely conservative industry. You know, we're all in rural areas, so you got to be really careful. And we're trying to have reasonable conversations with very conservative politicians, so I can't just get all emotional about it. But these are facts. This is not conjecture. Let's talk about the Affordable Care Act. First of all, why can't an alternative be found? Why have we been struggling? Oh, 2 weeks. 2 weeks. I have a plan in 2 weeks. 2 weeks. I have a plan in 2 weeks. Why can't we come up with a plan? Because Obamacare was a Republican plan. Mitt Romney came up with it. That's why it was such kind of a genius move politically for President Obama to co-opt the Republican plan. And it's left them flailing in a lot of ways ever since. It had two big objectives. We expanded Medicaid. So when we hear about Medicaid expansion, that's Obamacare. We increased the number of people eligible for Medicaid. And now we're trying to roll it back. The second thing it did is it created healthcare exchanges for people that are not qualified for Medicaid. They're probably employed in a small business or they own a small business, and their small business does not offer affordable health care. So we get these healthcare exchanges for people that are not covered by an employer plan. So here's Medicaid expansion. We got up to 138% of the federal poverty level, which, wow, seems generous, right? But try living on $15,000 a year. Try living on that. So first we expanded the ACA. Medicaid, prior to the ACA, was funded approximately, call it 50-50, state and federal funds. And one of the big Supreme Court cases that we got said, no, states can opt into expansion or not. So then we got this whole patchwork of states that chose expansion and states that did not. And so those states that chose expansion, the government, federal government, pays up to 70% of Medicaid funding. And some states go up to 90%. And all of the states that are having massive hospital closure issues are those that did not expand Medicaid. Funny how that goes together. Not really. States on their portion of the funding are permitted to finance the non-federal share of Medicaid from other sources, including state funds, dirty word, and provider taxes. So why do you think there's been such an effort to kill Obamacare? Because it's funded by a tax. Funded by a tax. Keep that in mind. I was a huge proponent of Obamacare because I am a hypochondriac. And I was worried about something like happening to me when my kids were small, and then I was going to die, and then my kids wouldn't remember me. And I just would catastrophize. And so when Obamacare came along, remember what all Obamacare did. Created exchange markets, requires employers to offer affordable coverage, and include several consumer protections that we would think would be taken for granted but are not. New regulations, so we have new taxes, we have new regulations, which are, of course, very dirty words in some circles, right? What did those do? First, it prohibits health plans from dropping you when you get sick, rescinding your coverage when you got a cancer diagnosis. Sorry, you don't have an insurance anymore. That was rescission, and Obamacare made that illegal. Requires employers to not offer affordable coverage to pay penalties with some exceptions. Prohibits lifetime coverage limits. My daughter has a condition that she's going to be an expensive person to cover, and now they can't kick her off when her cost of coverage exceeds $1 million. But what does the future hold? Good question. Rebates to enrollees and businesses if your large commercial health plan does not spend an appropriate ratio on covering care and has higher administrative / CEO salary costs. They pay, some of us got rebate checks when, I won't mention the insurance company's names, but they have too high of administrative costs and they have to pay rebates back to insured people. It's a big deal. And then that's where we get also, remember, our kids can now keep their coverage to age 26, which has been a lifesaver for many. Health care exchanges, we've heard the term subsidies a lot in the past several weeks, haven't we? And that's what's going away. That's why right now we're about to have, maybe not a healthcare Armageddon, but if I'm a person on a subsidized plan and my subsidy's gone away and all of a sudden my monthly premium is going up by $4,000, if you're in a certain actuarial age bracket, which I'm close to, You're going to be more expensive to cover, and you're going to have excessive increases in your premiums. And this is where these subsidies come in they subsidize those health plans to make them affordable. Now, here's a huge downside. Do you know the only reason the ACA passed? I was following it very closely. I've been a news junkie since about 1973 when Give 'Em Hell Harry came out, and I was a little kid. And for some reason, that movie really turned me on. And I've been a political junkie ever since and watched Obamacare closely. What happened in Obamacare? The law was written in the House, and it took away health insurance companies' ability to be monopolies. The bill went to the Senate. In the Senate version, the only reason health insurance companies signed on is because that antitrust provision went back in. Who gets antitrust protection? Public health utilities, Major League Baseball. Health insurance companies. So one negative outcome of the ACA has been legalized. This is the only way we got it passed. Legalized health care monopolies. That's why we have 2 or 3 big players in every state. And it's genius, too, because now you've got to go deal with 50 different state laws to address it. But this is one thing we're suffering from now. This is why you see a lot of hospitals that run into problems with whoever they have a contract with, one of the 2 big payers, and they remove that contract, but then the patients suffer. So this is a big negative outcome of ACA. Another, in my view, very negative outcome of ACA was the fact that physicians commoditized themselves. We took the power away from the physicians because what happens is all the physician practices around you started getting bought up so that healthcare entities could scale, and we've wiped out independent physician practices. We're compounded by a problem in Illinois where our rural health clinics have a pay scale based on a year 2000 consumer price index. So relative to the rest of the country, our rural health clinics get about 60 cents on the dollar relative to rural health clinics in Missouri, Kentucky, Texas, Tennessee, other places. So we've got a compounding problem that were some negative consequences of the ACA. Now let's talk about this ridiculously named legislation. One big, beautiful bill. First of all, it established work requirements which have been a proven failure. Because what happens? The paperwork is confusing. The paperwork is difficult for a lot of educated, knowledgeable, well-read people to fill out, and often it just really trips up Medicaid recipients. So we've established work requirements. We're exempting the work requirements for those who are frail or disabled. We're verifying, we have to, if the person hasn't met the work requirements for the previous 3 months, they will lose their insurance. We will disenroll people that don't meet the work requirement. We prohibit these provisions from being waived. So where states had power over their Medicaid programs, now we don't. We are exempting states from compliance with this until 2028. That's good news. That is good news. Hold that thought. On work requirements, we may have one time a year that we have to prove that we're eligible because we meet the work requirement. Remember, we saw 70% of our recipients are working, but now we've moved this to every 6 months. The Georgia model has seen a significant reduction in Medicaid recipients because people can't fill out the work requirement paperwork. And what happens if you don't have internet at home? What happens when you don't have internet at home? You're going to lose your Medicaid coverage. You're just going to give up is what has happened. FMAP. Healthcare, if you ever get involved in healthcare, you know we have an alphabet soup of acronyms. You got to learn all these acronyms just to stay current. And FMAP is the federal matching dollars that comes for funding Medicaid expansion. So one big beautiful bill eliminates FMAP. So that federal matching dollar that gets us to fund 90% of our Medicaid expansion, now we're going to drop back down to 50%, and states are individually going to have to come up with a funding mechanism for the rest of their Medicaid. So what are the states going to do? Cut. That's exactly right. We know that will happen. That will be the outcome of this FMAP. Largest reduces provider taxes. So not only do we eliminate the matching dollars, but we prohibit states from enacting provider taxes. So all of this talk about defunding, eliminating Obamacare, we're achieving that through the back door because we're cutting off all the mechanisms that make it work. That's the point. That is the point. Reduces the payments that require managed care organizations to make to healthcare providers. So we're removing a lot of those regulations that made the ACA a success. These tax credits removes the tax credits. So we as individuals, if you're on a healthcare exchange product and you're paying a certain amount of money, this is why it's gotten so expensive, because we would get a tax credit if I have to pay for those plans. And now the tax credit, the subsidy's going away, the tax credit's going away. So we've both directions making it more expensive to have health care if we're on one of those exchange products. So this is from KFF. There is no extension to the tax credits, and the number of uninsured people will rise by 4.2 million. One statistic I did not have in this is that one big balanced, one big beautiful bill represents a $880 billion cut to Medicaid over 10 years. In my book, that's a lot like $1 trillion. $880 billion cut. We'll have some other fancy stuff that none of us have access to. So, approximately 66 million people, 20% of our population, live in rural areas, and 25% of our adults are covered. And we cover nearly half, Medicaid covers half of all births. And so that's going to get wiped out when you have fewer Medicaid recipients. $137 billion our Medicaid spending will be reduced by. So all those critical access hospitals that rely on Medicaid populations, guess what? They're still going to see the patients. They're just not going to get paid for it. But ultimately, we will lose hospitals at an accelerated rate because of this. All rural hospitals, I can tell you, are deeply concerned about this. Now, there was a listing a few months ago about at-risk hospitals or hospitals are about to close in Illinois. And I can tell you a lot of the hospitals on that list were upset that they were on the list because it was not a super accurate reflection of all those hospitals' conditions. But those same hospitals only have a 1% margin. So any change, any reduction of their reimbursement, take a bunch of their Medicaid reimbursement out of it, and it will definitely accelerate hospital closure. So here's how we impact rural. 2.8 million Americans rely on plans purchased through the marketplace. Expiration of these subsidies will increase premiums by an average of 107%. And individuals are going to forego coverage. We've seen this before. This is why we had the ACA, because we had such large populations of uninsured people in the richest country on the planet. 350,000 jobs. 350,000 healthcare jobs are at risk. And phantom enrollees subsidizing health insurers were going to cost $380 billion. $380 billion. So we have this Rural Transformation Fund. We're supposed to get $50 billion to rural providers. We just had this huge application process, and we've all applied it. But guess what's the one thing we can't use the Rural Health Transformation Fund for? Making up Medicaid dollars. We can upgrade our software, we can participate in value-based care, we can start care management programs, but we can't replace Medicaid money with this. And $50 billion is less than half of the reduction we're going to see just in rural areas. This is just in rural areas. This does not include the healthcare desert we have in a lot of our urban areas. My office is in Soulard, and I look right out at some of the biggest healthcare deserts. I just go down Grand. And so this is just in rural areas that this is this impact. So $50 billion is helpful. It's not a small amount of money, but it also doesn't solve the problem. It's a political patch to say we're trying to do something. Now, here's the stalking horse. Sequestration right now is at 2%. It is based on the deficit. Medicare has a provision because of the increase in the deficit that is projected to occur because of one big beautiful bill. We're going to see an additional 4%. So it's going to be a 6% sequestration cut based on the increase in the deficit, because we have this law called pay-go. You got to pay as you go. Got to pay as you go. Now, here's the thing. A lot of these provisions don't kick in until after the election. Now, that's a cynical political move, but it's also a big opportunity, because these cuts will not take place for a couple of years. We're going to see, we already see right now immediately, the healthcare exchange prices of our premiums are increasing starting January. But all these Medicaid cuts don't kick in for a couple of years. So it provides us an opportunity. Here's this is the timeline. You can all look at this. It's all on KFF. Just go to all these acronyms. OBBB timeline, and you'll get this KFF document. That's the implementation. So I do a lot of lobbying. I have a trip I'm taking in February, and then another that my company is sponsoring in June, specifically focused on rural health, where a bunch of us from around the country convene on Washington, and we go all visit our reps. I had one of the craziest conversations I've had ever in, I won't name the rep, but they're from Alabama, and with the chief of staff. And he said to me, I brought up the Medicare sequestration problem. We were having a friendly conversation, then I brought up the pay-go 4%, and the dark shroud came down on his face. And he said, you know what? The problem is we just purchase healthcare all wrong in this country. I said, okay, so tell me. I'm sure you have some ideas on how that should happen. So he says to me, first of all, we got to kick all these lazy people off of Medicaid. Kick all the able-bodied people that can go out and get a job, kick them off Medicaid because they shouldn't be on Medicaid. And we need to kick off all the undocumented off of Medicaid. And that's going to pay for a big chunk of this, first. Then we're going to have price transparency. So a lot of us have seen the surprise medical bill thing. It's a total fallacy, and it does not reflect how healthcare gets paid, because your prices are increased everywhere you go, so that I price everything so every payer I have, all my commercial payers and everybody else, I'm going to be over what they're going to pay me, so I don't take any cuts. So I'm going to price myself at $200 because I have a commercial plan that pays me $195. I have a lot of other plans that may pay me less, but that's why we have such dramatic price inflation for healthcare. So price transparency isn't going to get you there. But this guy says, well, if you have price transparency and I need a heart transplant, there's one guy and he has it posted on his wall and he says the heart transplant's going to cost $12,000. And then you have another guy and he's going to do the same transplant for $45,000. So, of course, everybody's going to go to the $12,000, and the other guy's going to have to lower his prices. And I thought, well, first of all, no, I don't think I want the bargain discount heart transplant, A. And B, that is not how any of this works. So it just demonstrated vast ignorance on how this works. But this is what we get. So then between kicking all the able-bodied people off of Medicaid and price transparency, then we're going to have HSA, health savings accounts. And then your insurance should only be catastrophic insurance if you get cancer or get in a car accident, and everything else is out of pocket. And I thought, dude, okay, I just need to move on to the next office here because we're two totally different planets from one another. But that's where one side of the argument is made. And then strengthen Medicare Advantage, which means what? Increasing private, for-profit health care. And then we're going to do that by defunding Obamacare. So this is kind of one side of the argument here that I personally, I'll speak for myself, think is a fool's errand. Now, when we talk about our Democratic responses, we see we just want to get back to the status quo. Fully fund Obamacare, strengthen our Medicaid and our insurance exchanges. So these are kind of the two flavors of the conversation that are happening. And we're not having a lot of compromise for folks anymore. So that's where we are right now. So right now we have an opportunity to change the conversation before these cuts happen. And it's going to take us and people like these rooms to talk to our legislators and say, hey, that is not what we need. Go express yourselves. I won't put words in your mouth. But so there you go. Universal health care. Yes, Medicare for all. I don't think any of us in this room will see it in our lifetime. I think yes, that's where we need to go, but I don't think it's a realistic outcome for us because 25% of our GDP are healthcare dollars.
Unless we move to any other industrialized country in the world.
And my niece in Australia has Medicare for all. She had an overnight stay in the hospital, an elaborate scan. It cost her $300, and she wasn't even covered yet.
But the people that go on these cruises and stuff, they go overseas, they get, if they have to go into a hospital, I think they said, one person said their bill was $100.
$100. Now, so that's true. Here's my personal thought. This is Charles James speaking, not my company, nobody else. Medicare works great. Medicare is an efficient, inexpensive insurer. My personal thought is we eliminate the healthcare exchanges and we open Medicare up for 50 and above. And you get all the people on these now subsidized plans and get them on Medicare. Everybody pays for Medicare Part B. We pay for Medicare Part B. And those premiums will go a long way. And theoretically, 50 to 65-year-olds are less expensive to insure than the 65 plus. We spend about 50% of our Medicare dollars in the last 6 weeks of a patient's life. So my personal hope, I would love to see universal health care. I don't think it's a realistic goal for any of us in this room to see, but I think we can move towards that. So first, let's get this current crisis resolved. We just saw what happened in elections 2 weeks ago when we put our minds to it. Politicians do listen to us. So we have a big push now, between now and just after the midterms, when the next election takes place, to change this curve. We can still change it. All we need is legislators that will vote on a reasonable bill. So there's hope. We're in a crisis situation. We have time to resolve it, and we have to decide where we want to put our healthcare dollars. I think it's expanded Medicare. I don't hear anybody talking about that. So believe me, my little voice doesn't get very far. But that's what I would like to see. That's what I would like to see. So that's the one big beautiful bill and what we're looking at. A massive, if this goes into effect as is, which I don't think it will, personally, I think we'll get some changes made to it. But we're going to have to work really hard to do that. But if this status quo stays, we will have a healthcare Armageddon. We're gearing up for that. And it's up to all of us to change that curve. Yes, sir.
Those of us who are on private plans or employers or whatever, are our costs going to go up too when
Absolutely.
exchanges blow up?
Absolutely.
We just got ours.
You just got yours.
Yeah, ours went up $310 per paycheck, so twice.
Per paycheck.
Mine
On
was
private
like
insurance.
30% from last year on my employer.
It's going to affect every commercial health plan out there. Yes.
I'll tell you where it's really bad, and I can justify that from I'm aging myself back in the late 70s when a lot of people were laid off of work. And that's when they started that if you lost your job, they had this other plan.
Oh, no.
But it was like, do you pay $700 a month to give health care to your family, or do you pay your mortgage?
And now that $700 is probably
And you're
$2,000.
only getting $300 in unemployment. So where does the money come from? Yeah. And I can remember the day when, like you said, when you're unemployed, you're kicked off of all your benefits.
Right.
And then if you started a new job, they held back your benefits for 3 months.
Mhm.
And then you were entitled to benefits. And then if you were pre-existing on anything, they didn't have to insure you.
And I didn't talk about the pre-existing conditions at all, but yeah, you could just not get insurance
Yeah.
in the first place. Our
Yeah.
daughter would be uninsured.
Yeah, and that happened a lot.
Happened a lot.
Or a sick kid hits their limit by the time they're, 18.
20, yeah.
Yeah.
Absolutely. And it happens, we have chronic illnesses.
Yeah.
And
It's a
the price
fact
of
of life.
everything's going up, so.
Price of everything, and healthcare inflation is drastically surpasses just regular inflation in the rest of the economy. Well, thank you very much for listening. I appreciate it. Thank you.
All right. I don't know about you, but I have several questions that I'll be wanting to ask them. We do have one more speaker, plus we'd like to give Julie some time. So if you do have some questions, just hold on to them, and we will try to get some time at the end. But one question I want to have is Mr. James, how he has an unemotional conversation with... You might need to give a session on that, how to. Okay, I don't know if I can do that, but all right. Kathleen, thank you for the tip on Mr. James too. Appreciate that.